the YouTube viewers. Welcome to webinar on radiology of skull base anatomy. As we all know, skull base is complex structure, difficult to understand, even more difficult to approach and treat the diseases of the skull base. It requires multidisciplinary team of approach, including neurosurgeon, otorhinolaryngologist, radiologist, etc. Recent advancement in radiological diagnosis, neuroradiological invasive procedures, endoscopic approaches made skull-base lesions approachable and curable. Today's webinar on radiology of skull-base anatomy will be delivered by Dr. Ullas Acharya, consultant radiologist from Manipal Hospital, Bangalore. He had completed his MD radio diagnosis from KMC Manipal, DM in neuroimaging and interventional radiology from Nitte. He was awarded Best Outgoing Students in Radiology in 2016 from Nitte. Presently working as consultant radiologist in Manipal Hospital, Bangalore. Skull base has been one of his interests. Thank you very much for being with us today.
Thanks, Rifat, for the invite. Looking forward for a good 1 hour session with you people now.
I welcome our VC sir, Dr. Satish Kumar Bandari. Thank you very much for being with us, sir, today. It was his idea to organize these type of webinars. Welcome you, sir. I welcome all the YouTube viewers. Thank you. Over to VC, sir.
Very good evening. Very distinguished guest speaker, Dr. Ullas Acharya, consultant neuroradiologist from Manipal Hospital, head of the Department of ENT, Dr. Rajeshwari, Dr. Vadish Bhatt, and faculty of the Department of ENT, postgraduate students, and the participant in this webinar. It gives me immense pleasure to be part of this webinar series. I understand this is fourth in the radiology of ENT. I congratulate the Department of ENT for conducting this very interesting webinars for the sake of postgraduate students and the faculty and young ENT surgeons who are interested to learn more about the radiology of various structures in head and neck and ENT. I thank Ullas for agreeing to participating in this webinar. On behalf of the not only the department, I am the part of the department, also on behalf of the Nitte deemed to be university, I welcome you to this webinar. As Professor Rajeshwari said, the anatomy of the skull base is very, very complex because of the various structures, particularly neurovascular structures. Anybody venturing to the skull base, ENT or neurosurgeons, they must be well versed with the complex anatomy of the skull base. And the best way to learn is the CT and MRI, and the combination of these two. I think I understand Ullas is going to deal with this particular area in very diligently and very elaborately for the sake of the participants' webinar. I wish success for this webinar, and I hope all the participants will carry very fruitful webinar and they'll have very interesting facts about the skull base anatomy. Thank you very much for giving this opportunity to inaugurate this webinar on skull base anatomy. Thank you. Thank you very much.
Thank you, sir. Over to Dr. Ullas.
Yeah, so thanks for the kind introduction, as well as I think sir has given a right introduction in saying that skull base anatomy is a complex subject, which I'll try to cover in the next 1 hour, trying to make it very simple. Covering the broad line of this talk would be covering the basic anatomy first, followed by the radiological anatomy, which would include both the CT and the MRI images. So for the next 1 hour, I think I would keep all of you engaged with this presentation. So I'll go ahead with the presentation. So you're able to see my slides, right?
Yes, sir.
Yeah. So, we'll first, as I said, we will talk about the anatomical boundaries of the skull base, slowly go on to the radiology, because radiology is definitely based upon anatomy. So if we know the gross anatomy, then it make the reading of both CT and MRI quite easier. So the skull base boundaries anteriorly, to keep it very simple, it's the incisor teeth, whereas in the lateral part, we have the zygomatic arch, and more laterally, posterolaterally, we would have the mastoid process, and further posteriorly, we would have the superior nuchal line. This is in gross to define the boundaries of the skull base. What forms the bones of the skull base also is an important thing, as we see on the next subsequent slides when we get the CT and the MR images. The anterior skull base is mainly formed by the frontal bones and the ethmoid bone, whereas the middle cranial fossa is predominantly formed by the sphenoid bone and the temporal bone. And the posterior cranial fossa is mainly formed by the occipital bone and also portions of the basi-occiput part of the clivus and the petrous bones. So these are the main bones which would form the skull base for us. So again, the anterior cranial fossa, as we saw, it's formed by the orbital plates of the frontal bone and the ethmoid bones, which would form the crista galli and the cribriform plate. And of course, the posterior end of it would be the lesser wings of sphenoid and the anterior sphenoid body. So this is to show that the anterior cranial fossa from the frontal view, when we have the frontal bones, and in between would be the ethmoid bone. This forms the boundary of the anterior skull base, where we have the orbital plate of the frontal bone forming the roof of the orbit. In between the two frontal bones will be the ethmoid bone. Talking a little bit about the anatomy of the ethmoid bone, that is important here again. So it is divided into a vertical or a perpendicular part, and then the horizontal part, and a lateral lamella, also called as the ethmoidal labyrinth. So when we have the vertical plate, at the top of it would be a bony structure, triangular bony structure called as the crista galli, as we can see here. And it is immediately followed by part of the anterior skull base, where sleeve-like structures are present, letting the olfactory nerves traverse from the nasal cavity to the cranial cavity. So these are called as the cribriform plate. These are also the common sites to have the CSF rhinorrhea. So it is important to know this anatomy, that this would be called as the cribriform plate. Immediately lateral to that would be the lateral lamella, and further laterally would be the fovea ethmoidalis, which forms the thinnest part of the skull base. So we have the vertical plate, we have the horizontal plate, which includes the cribriform plate, the lateral lamella, and the fovea ethmoidalis. The lateral lamella, or the ethmoidal labyrinth, divides the nasal cavity from the orbital cavity. So lateral to this, we would have the orbit, and medial to this would be the nasal cavity. So this is a gross anatomy of the ethmoid bone. So these are the parts which I have already discussed on the images. So on a sagittal view, the one which is colored in the green would represent the ethmoid bone, which would include the superior and the middle concha. It is again important to note here that the superior and the middle concha are considered to come from the ethmoid bone, and they are a part of the cranial bones, whereas the inferior concha would be considered to be part of the facial bone. So that distinction is also important to note. So the relations of the anterior cranial fossa, it's quite simple, that inferiorly it is related to the orbital cavities, and the midline to the nasal cavities. And superiorly, we would have the frontal lobes being placed. We'll come to the detailed CT anatomy a little later of these structures. So the middle cranial fossa is formed mainly by the body and the greater wings of sphenoid. Also the parts of petrous part of the temporal bone. The anterior limit is formed by the sphenoid bone and body and its lesser wings, whereas the posterior limit would be formed by the dorsum sella. So again, we can see the middle cranial fossa here, which is predominantly formed by the sphenoid bone, the petrous bone, as well as the parts of the temporal bones, basically. Then at the midline, we would have the sella turcica, which would where the pituitary gland could be lodged. Yeah, so these are the important contents of the middle cranial fossa, which include the temporal lobes, the pituitary gland, the cavernous sinus, and the most important thing is the cranial nerves 2 to 6. So this almost most of the important parts of the cranial nerves, including 2 to 6, would be coming from the middle cranial fossa, whereas the first cranial nerve, that is the olfactory nerve, would be from the anterior, and the rest of the cranial nerves would be from the posterior cranial fossa. So just to define the limits of the posterior cranial fossa, anteriorly it is by the clivus, whereas anterolateral would be the petrous ridge, and the posterior aspect would be the occipital bone, as we have already seen in this image. So just reiterating the same points here. So the contents of the posterior cranial fossa, important ones would be the pons and medulla, that is brainstem. Of course, at the foramen magnum, we would have the cervico-medullary junction with transition between the cervical cord and the medulla. It would lodge the cerebellar hemispheres, which is of course bilateral, and then we have extraaxial structures, which would include the dural venous sinus, the internal acoustic meatus, and the vestibular aqueduct, the jugular foramen, and hypoglossal canals. We would see all of these shortly. So again, to show the boundaries of the posterior cranial fossa and the bones which are forming this, which I've already discussed. So some of the important foramens which we see in the posterior aspect would be the larger foramen here would be the foramen magnum, through which the brainstem would pass through, and that's the transition between the medulla and the cervical cord. We have more laterally the jugular foramen, and further inferiorly and medially we would have the hypoglossal canal. The clivus is basically a bone which has two components. One is the sphenoid component and the other one is the occipital component. We call it as the basi-sphenoid and the basi-occiput parts of the clivus. So the basi-occiput part of the clivus would form a component of the posterior cranial fossa. And of course, the larger part here is formed by the occipital bone. So through the jugular foramen, the 9th, 10th, and 11th cranial nerves will pass through, and through the hypoglossal canal, the 12th cranial nerve will pass through. So these are the cranial nerves which pass through the posterior cranial fossa. So coming to the jugular foramen anatomy, so it is divided into two components here. One is the pars nervosa and the other one is the pars vasculosa. Though the name is a misnomer, because though it is called as pars nervosa, we can see there are both venous elements as well as the neural elements going through. And similarly, in the posterior components, we see compartment, we see both veins as well as the nerves going through. But grossly, to remember, we can take that the 9th nerve and the inferior petrosal sinus, these pass through the pars anterior component, which is called as the pars nervosa, and the vasculosa component is predominantly because of the internal jugular vein. So in the posterior compartment, we have the 10th and 11th cranial nerves as well as the internal jugular vein passing through. So in simple words, nervosa anteriorly, vasculosa posteriorly, nerves being glossopharyngeal nerve anteriorly, vasculosa for the internal jugular vein posteriorly. So the same thing which is described here, the anterior component, the posterior components with their contents. The sphenoid bone, it forms the fundamental structure of the skull base, and it contains the sella turcica and the cavernous sinus. It lodges many foramens within and connects the intracranial to the extracranial compartments, which we would shortly see. So these are the parts of the sphenoid bone, again important to understand on the CT and the MR as well. So the blue representation would be the main body of the sphenoid, and the green color here would be the lesser wing of sphenoid, which would end up forming the anterior sphenoid process more posteromedially, and this would also extend to form a portion of the roof of the orbit. Whereas more laterally, when we go, we have the greater wing of sphenoid, which in the superior aspect forms the orbital plate, which would form the posterior wall of the orbit. And then we have the main portion of the middle cranial fossa being formed by the rest of the greater wing of the sphenoid, which lodges 3 foraminae within. So this foramina is easy to remember in the anteroposterior direction with a mnemonic called as a ROS that stands for foramen rotundum anteriorly. In the middle, it is the foramen ovale, which is a larger foramen out of all the three. And then further posterolaterally, we would have a smaller foramen called as the foramen spinosum. So we would see what passes through all this as we see ahead. In addition, it has a pterygoid plate, pterygoid bone, which has two plates. One is the medial plate and the lateral plate. In between the two would be called as the pterygoid fossa, and the medial most, the tip of this medial plate would be called as the pterygoid hamulus. So this forms in general the portions of sphenoid bone, which is very important for the middle cranial fossa. So in between the body and the lesser wing of sphenoid anterior clinoid process, we would have the optic canal. Superior orbital fissure is situated more lateral to the optic canal. It is situated between the two wings, that is the lesser and the greater wing. Whereas the optic canal is situated between the body and the lower wing of sphenoid. So this image is very important for us to understand the basic anatomy of the middle cranial fossa. Again, to show on a different aspect, the anterior view shows us the sphenoid sinus and the intersphenoid ridge. This is the left wing of sphenoid on traversing across the sides. It would be the body of sphenoid. This is what I was calling as the orbital plate of the sphenoid bone, which is forms the posterior aspect of the roof of the orbit. So in between the greater and the lesser wing, we would have the superior orbital fissure. And of course, not in this section, it is not shown, but between the lesser wing and the body of sphenoid, we would have the optic canal. There are two other foramens, the foramen rotundum, which is better seen on the coronal plane than on the, as well as in the axial plane. Whereas the foramen ovale can be seen on both this plane. In the medial, we would have a foramen, the pterygoid canal. So as we see here, this is shown. This is the pterygoid canals here, and this is the pterygoid plates, the pterygoid bones, which are component of the sphenoid bones here. So having introduced the concept of superior orbital fissure, let's see what are the contents which pass through the superior orbital fissure. So one thing we realized is the optic canal is placed more medially as compared to the superior orbital fissure, which is placed more laterally. The superior orbital fissure is further divided into three compartments, the superior, central, and the inferior compartments. Let's not go into the divisions of these further, but let's keep it simple, saying that the optic canal would carry two structures, the optic nerve and the ophthalmic artery. Whereas the superior orbital fissure carries all the nerves which supply the extraocular muscles. So that would include the 3, 4, 6 nerves within it, as well as it would include the branches of the trigeminal nerve. So main purpose of the superior orbital fissure is to let the nerves which supply the extraocular muscles from the intracranial compartment to enter into the orbit. So that is the basic basic funda of this superior orbital fissure. So all the nerves supplying the extraocular muscles and the branches of the trigeminal, some of the branches of the trigeminal nerve would form the main components of the superior orbital fissure. And what we see here in the green would be the annulus of Zinn, which is from where all the extraocular muscles would arise. So we can see a very close knit relation between the annulus of Zinn, the optic canal, and the superior orbital fissure. The superior orbital fissure and the optic canal are together called as the orbital apex. So this is the area which gets involved in Tolosa-Hunt syndromes, or the idiopathic orbital inflammations, where the inflammation can extend intracranially as well as into the orbit, involving this orbital apex. So these are the main structures which would be involved. So further dividing it into upper, middle, and lower. So these are the different contents which I will not stress upon. So the main purpose is for the letting in of the extraocular muscle nerves. So that would include the 3, 4, 6, and of course the ophthalmic division of the trigeminal nerve. Then we have the inferior orbital fissure. Again, we try to remember only one thing here, that it allows the maxillary division of the trigeminal nerve. So why is this inferior orbital fissure important? We will see further ahead that it has connections with certain areas of the middle cranial fossa, where which lets in the maxillary division of the trigeminal nerve coming in, which further courses along the floor of the orbit as the infraorbital groove, in which the infraorbital nerve is placed and then traverses ahead. This is one of the commonest probably nerves which we see being involved in this pandemic because of the mucormycosis. So this forms an important pathway between the orbit and the skull base. So inferior orbital fissure would give us the main nerve which passes through would be the maxillary division of the trigeminal nerve. So this is the superior view, again, just to give a clear view of the different canals, the optic canal being superomedially in relation to the superior orbital fissure. Canal is wedged between the body and the lesser wing. The superior orbital fissure is wedged between the greater wing and the lesser wing. This is the sella turcica. So again, the lesser wing ends up forming something called as the anterior clinoid process. And this base would be the optic strut. Again, this optic strut is very important landmark for us to know the vessel, whether it is intracranial or extracranial in location. Intradural or extradural in location. What that means is an intradural aneurysm is highly, it can cause, if it ruptures, if there is an aneurysm in the intradural location of an internal carotid artery, it can cause subarachnoid hemorrhage. And that means to say bleeding within the cranial cavity, whereas aneurysms, say, which are extradural in location, usually cause caroticocavernous fistulas. So they do not directly cause intracranial complications. So that becomes an important landmark. Sometimes when you look for the aneurysm, whether these are related, superior or inferior to this optic strut. So that is an important landmark to note. The sella turcica as such is bordered anteriorly by the tuberculum sella and the posteriorly by the dorsum sella. Sorry, this is the sella turcica, whereas anteriorly this would be the tuberculum sella. This would be the dorsum sella, and these processes would be called as the posterior clinoid process. These are the three foramens which we are talking about: the rotundum, ovale, and spinosum. ROS in the antero-posterior order: rotundum, ovale, and spinosum. Yeah, so anteriorly to posteriorly, these are the three main foramens which we come across the middle cranial fossa, which includes rotundum, ovale, and spinosum. Through the rotundum, as we see, it is what passes through is the maxillary division, whereas through the ovale, it would be the next division, that is the mandibular division of the trigeminal nerve would pass through, whereas spinosum lets in an important structure called as the middle meningeal artery from the extracranial compartment to the intracranial compartment. So these three would be the main structures to remember within these foraminae. This is to show the sella turcica and how it resembles that of back of a horse, where anteriorly it is the tuberculum sella, whereas posteriorly it is the dorsum sella, and in between we would have the pituitary gland being lodged. And of course, this is in the sagittal view. In the paracellular area, it would be the cavernous sinus. That is what we see here. So this, if we take it as the sphenoid area, so this would be the lateral aspect where the cavernous segment of the internal carotid artery would pass through, and anteriorly we have the optic chiasma being placed, and there are various nerves which are in relation to the cavernous sinus, which we would see in the next slide. So again, an important anatomic landmark to know what are the contents within the cavernous sinus here. So again, mnemonic to remember this is CAT in terms of medial to lateral. CAT means C stands for the internal carotid artery, A stands for the abducens nerve, and T stands for the trochlear nerve. So these would be the three structures which are located from medial to lateral. In addition, we would have the third nerve and the ophthalmic and the maxillary divisions of the trigeminal nerve being placed along the lateral wall of the cavernous sinus. So again, important to remember the relations and the structures which are associated. So when there is a pituitary macroadenoma, we grade it based upon how much of this cavernous sinus is encased by the tumor. That's something called as the NOS criteria. Depending upon whether the medial margin, the in-between, or the lateral margin of the ICA is encased by the lesion or not, the classification goes on like that. So it is important to remember these structures. Again, just the posterior view, we have covered most of this anyway, so it is just to reiterate the same points here. On a sagittal view, what is important here is this: the sphenoid bone would form the roof of the nasopharynx. So it becomes directly in relation to the nasopharynx, whereas the ethmoid bone, as we saw, was in relation mainly to the olfactory nerves through which pass through the cribriform plate into the olfactory bulb, whereas posteriorly the sphenoid bone would form the roof of the nasopharynx. Again, these parts I have already told you in the prior images, so we'll just skip that. Yeah, so when we look at the choana, again, relations with the choana is important, as we see that this is just to show where exactly the pterygoid bone, this bone, where exactly it would come in relation to the choana. So this blue line would represent the pterygoid plates, whereas this would be the vertical and the horizontal parts of the palatine bone, and this would form the vomer. So this is an important, again, relation to know in relation to choana what are the walls it is formed. So medially related to the vomer, whereas inferiorly it is formed by the palatine portion of the palatine bone, which forms the posterior aspect of the hard palate, and laterally we would have this pterygoid bone. So in between the medial and the lateral pterygoids, we have the pterygoid fossa, and the thickening which is seen along the medial end of the tip of the medial pterygoid plate would be called as the pterygoid annulus. This is in the sagittal view, this being anterior and this being posterior. So this is intracranial, this is extracranial. So when I say this is intracranial in the middle cranial fossa, this becomes the temporal fossa, this becomes the infratemporal fossa. So on the outside, on the temporal, in the sphenoid bone, we have something called as the infratemporal crest, which divides this component. One of the component of the greater wing of sphenoid is related to the cranial fossa, whereas the other component is related to the infratemporal fossa. So what divides is the infratemporal crest. Anterior to this, we have the pterygomaxillary fissure, which would form again a connection between the pterygomaxillary fissure to the infraorbital fissure. So that becomes another important landmark for us to know. So whatever we discussed about the sphenoid bones is shown in all three planes, just to get an orientation of where these bones are placed. Talking about the temporal bone, we have different parts of the temporal bone, which includes the squamous temporal bone, the zygomatic process, the tympanic process, the styloid process, and the petromastoid process. What forms a component of the skull base would be the petromastoid component. This is an important component of the skull base. The rest of the bones are usually placed outside. So important relations of the petrous temporal bone. See, if we take this as the medial temporal petrous bone and the directions as mentioned here, anterior, posterior, lateral, and medial, this would represent the foramen lacerum. Petrous bone lodges the middle ear and the inner ear cavities. So the roof of the middle ear and the inner ear is formed by the petrous bone. Anteriorly, we see a connection going to the eustachian tube, which would enter into the nasopharynx further anteriorly, whereas posteriorly, we would see the internal auditory canal as well as the vestibular aqueduct. So these are some of the important relations of petrous temporal bone. And further anterior but little lateral compared to the foramen lacerum would be the Meckel's cave, through which the trigeminal nerve ganglion would pass through. And the posterior view, two important structures to note would include the carotid artery and the jugular vein placed within the carotid canal and the jugular foramen or the jugular notch. So this is just to show the anterior and posterior relationship between the artery and the jugular vein. Yeah, so let's spend some time in this slide here to know the cranial nerves which pass through. As I briefly told before, that the second cranial nerve is, the first cranial nerve is in relation to the anterior skull base, where the olfactory bulb and then the olfactory nerves pass through here, whereas the optic chiasma comes through the optic canal. We have the ROS, that is the rotundum, ovale, and spinosum. And we know through the rotundum, we discussed that it is the maxillary division which passes through. Through the ovale, it is the mandibular division which passes through. And through the spinosum, it is the middle meningeal artery which passes through. Further posteriorly, we have the internal auditory canal through which the 7th and the 8th cranial nerves pass through. And medially, we would have something called as a duralos canal through which the abducent nerve pass through in the posterior cranial fossa. Jugular foramen we saw divided into two components, the nervosa and the vasculosa, in which the 9th and 10th and 11th cranial nerves will pass through. And finally, we have the further below in the medial aspect, we have the hypoglossal canal through which the hypoglossal nerve passes through. So these are the various cranial nerves in relation to the skull base, this thing. So this is the Meckel's cave area where the trigeminal nerve ganglion would be placed. Again, an important anatomical figure to show the three different branches or the divisions of it: the ophthalmic, the maxillary, and the mandibular. The ophthalmic would pass through, as we saw, through the superior orbital fissure into the orbital apex, going into the orbit there, whereas we have the maxillary division, which passes into the pterygopalatine fossa here, and through that into the infraorbital foramen and in relation to the maxillary sinus and the nasopharynx. Whereas the mandibular division passes through the foramen ovale into the extracranial compartment. The maxillary division would pass through the foramen rotundum. So the superior division would go through the superior orbital fissure, the maxillary division would go through the rotundum, and the mandibular division would pass through the foramen ovale. So I know it was a lot of anatomical images, but anatomy was necessary for us to understand the CT images, which I would be showing further ahead from now. So with the knowledge of the anatomical structures which we talked about, we would now see the CT images. So this is the coronal views. First, we go through the coronal sections, and then we'll go through the axial sections. In the coronal view, this is the frontal sinus, which is formed, of course, by the frontal bones. These are the frontal process of the maxilla. So these are portions of maxillary bones, and in between we would have the ethmoid bone being lodged. So we know the frontal, ethmoid, and the maxillary bones. So these are the frontal process of maxilla, ethmoid, and the frontal bones here. Further behind, as we go, we see portions of the nasolacrimal duct, and then again the same frontal sinus walls, which would separate the orbit from the anterior skull base. Yeah, so in this structure, these would be the main bones. Further, we would see this is the infraorbital foramina, which I was talking about, through which the maxillary division of the trigeminal nerve would pass through. We know it passed through the foramen rotundum in the brain, then it went through the pterygopalatine fossa, and from the pterygopalatine fossa, it has come into the infraorbital foramina. So this would be the infraorbital foramina on the coronal CT cuts. So here we get to know the ethmoid articulations, which we saw in the initial depictions. The triangular bone or the overt bone, which we see here in between, would be called as the crista galli, whereas these are the olfactory grooves, common areas to be involved in injuries. The olfactory groove boundaries would be formed by the cribriform plate inferiorly, whereas those sleeve-like structures would be present to allow passage of the olfactory nerves. Then laterally would be the lateral lamella, and further laterally, this would be the fovea ethmoidalis. So these are the boundaries of the olfactory groove. And based on the depth of this olfactory groove, we have three types as classified by Quiros. That is called as a Quiros classification. Let's not go into that. Again, just zoomed image just to show the same thing: the crista galli, the cribriform plate, the lateral lamella, and the fovea ethmoidalis. As we go further behind, now we start seeing the orbital apex here. So these are portions of the, here what we see is 1, 2, 3, 4. These are the muscles, extraocular muscles which are coming up. So we know we are going closer towards the orbital apex. That happens when we start seeing the temporal lobe. So this is the area of the temporal lobe. And these are the portions of the sphenoid bones which we come across here. So once the sphenoid bone starts coming in, once the anterior temporal lobe starts coming in, that's the point where we have reached the orbital apex. And this is just the beginning of the inferior orbital fissure, which we would see here. And this is just the beginning of the superior orbital fissure. So middle here, it's predominantly formed by the ethmoid bones. And this would be the lesser wing of sphenoid, and these would be formed by the greater wing of sphenoid. One which we just spoke about and didn't cover in detail was the pterygopalatine fossa. So that I would like to cover based on this, because this CT image would show the anatomy quite well. So this fossa on the coronal CT image is the place of the pterygopalatine fossa, which has various communications. Like superiorly, the communication is to the orbit through the inferior orbital fissure, whereas medially it has communication with the nasal cavity through the sphenopalatine foramen, whereas laterally it has communication with the infratemporal fossa through the pterygomaxillary fissure. So these are the major relations of the pterygopalatine fossa. And of course, posteriorly, which we cannot see on this coronal image, would be to the middle cranial fossa into two foramens. One is the foramen rotundum and the other one is the Vidian canal. So again, so this is the inferior orbital fissure. This is the pterygopalatine fissure. Medially into the nasal cavity, communication into the nasal cavity through the sphenopalatine foramen, and laterally into the infratemporal fossa through the pterygomaxillary fissure. So these are the communications of the pterygopalatine fossa. As we go further posteriorly, now we start seeing proper sphenoid sinus. So important other structures which we saw in the anatomical slides before would include the pterygoid bone and its two plates. So this would be the medial pterygoid plate and this would be the lateral pterygoid plate. In between the two plates would be the pterygoid fossa, which is placed. And this is the pterygoid hamulus. So medial and the lateral pterygoid plates, and in between the pterygoid fossa. Superiorly, between the body of the sphenoid and the lesser wing of sphenoid, we have a canal called as the optic canal, through which the optic nerve passes through. So this is the area of the optic canal, and this would be the optic strut, which I have already told the importance of the optic strut. So that is an important structure for us to note. And we have two other different foraminas here. This is the foramen rotundum, and this is the better seen on this side. It would be the Vidian canal or the pterygoid canal. So the foramen rotundum is a connection to the pterygopalatine fossa. This also leads to pterygopalatine fossa, but posteriorly this directly goes into the foramen lesserum near the carotid canal, unlike the foramen rotundum, which is an independent foramen along the middle cranial fossa, as we have noted before in relation from anterior to posterior, the ROS, the rotundum, mobile, and spinosum. So in the coronal structure, coronal sections, this is the foramen rotundum, this is the pterygoid or the Vidian canal. So these are the important structures which we come across here. Yeah, so better seen on this image, the foramen rotundum and the Vidian canal. So note the relationship between the two. The foramen and the Vidian canal, the pterygoid canal, is a smaller structure and it's placed much more medially as compared to the larger foramen rotundum, which is placed more laterally and superiorly. Again, we can see the optic canal, the optic strut here. So this smaller thing would be the Vidian canal. Again, it's a communication between the middle cranial fossa, posteriorly directly open into the foramen lesserum, which would be along the anterior part of the petrous carotid artery, and anteriorly it will go into the pterygopalatine fossa. This is the next foramen. Now we are going further posteriorly. The roof of the sphenoid sinus is being seen here, which is formed by the tuberculum sella, and at this level we are seeing the larger foramen, which is placed here, which is called as the foramen ovale, through which the mandibular division of the trigeminal nerve would pass through. So now these are very important relationships for us to know, because sometimes malignancies, infections, and all can have perineural spread from the intracranial to the extracranial spaces through these foraminae. So this larger, well visible foramina on the coronal section at the level of the sphenoid sinus would be the foramen ovale. Further posteriorly, as we go, we come into the petrous bones. So where we see the relationship between the anteriorly, we would have the internal carotid artery, and much slightly more posteriorly. So we are seeing only a portion of the vein coming up here. That would be the internal jugular vein. So because we see it further posteriorly on coronal section. So at this section, predominantly what we see is the carotid canal and portions of petrous bone which comes in. Further posteriorly, it would form a proper petrous bone, which would lodge the middle ear and the inner ear contents. So of course, I would not go into the details of the middle ear and inner ear, not the scope of this talk as such. So just to know that the petrous bone would include or would cover both the middle ear and the inner ear components. And now we also start seeing the basic sphenoid and the basic occiput portions of the clivus and the cervical vertebrae coming in. So this would be the jugular bulb. So anteriorly we saw the carotid canal, and here we see the jugular bulb being placed. Just to talk about the course of the facial nerve. So initially it is along the medial wall. Here, which is depicted in the yellow, would be the facial nerve between the cochlea and the middle ear's medial wall, and then it courses posterior along the posterior wall, and finally has a vertical component, which is the stylomastoid component of the nerve. Not seen on this section. I would show it in a different section. So at this initial section, we would see it being placed between the cochlea and the middle ear ossicles, somewhere here, and further down they would be placed below. I think I have an image. I would show it further ahead. So yeah. So we can see it here. This would be the internal auditory canal, of course, through which the 7th and 8th cranial nerves would pass through. So this is the dot which we can see, where the facial nerve is placed between the cochlea and the middle ear, medial wall of the middle ear. And further, as it comes down on this section, actually we can see it that it is placed below the level of the horizontal semicircular canal. And then finally what we see is the vertical component further behind, and that is called as the stylomastoid component, of the vertical component of the facial nerve. So what we see here in addition is also the jugular bulb, which comes down here, and the vestibular aqueduct, which is placed further supero-medially to this, the jugular foramen. Another important structure when we come posteriorly in the coronal view, and which is likened to that of a eagle head and a beak, is the jugular tubercle. So this is again an important landmark, because this is an important area where meningiomas and other infiltrative lesions can be associated, and these infiltrative lesions or skull-based pathologies can result in the dehiscence or involvement of this bone. So what we need to see is the integrity of this eagle head appearance. So eagle head, this is the beak. So it divides basically the hypoglossal canal from the jugular foramen. So that is an important thing again. So this is the hypoglossal canal, this is the jugular foramen, this is the eagle head, this is the eagle beak. So in relation to the neck, we have the hypoglossal canal. In relation to the beak, we have the jugular foramen. And superomedially, we saw it's the aqueduct which is placed. These are, of course, the superior and the horizontal semicircular canals, and the cervical vertebrae, which we see on the coronal sections. So from anterior to posterior, finish the coronal sections. Let's now concentrate on the axial CT sections. So the initial view would include the frontal sinus, of course, by surrounded by the frontal bone. And then we have the roof of the orbit, which is formed initially by the orbital plate of frontal bone, and similarly behind it is formed by the orbital plate of the greater wing of sphenoid. So we have portions of sphenoid as well as the frontal bone forming the roof of the orbit here, the posteriorly being the sphenoid bone, which is depicted in green on this image, and the yellow ones would be the frontal bones. As we go further posteriorly, I have shown you about the lesser wing of sphenoid terminating into the anterior clinoid process. So this would form the anterior, this triangular structure here would form the anterior clinoid process. So this is how a relation of the optic nerve, optic canal to the anterior clinoid process would be. So this is the laterally would be the anterior clinoid process. And this is the body of sphenoid. This is a component of the lesser wing of sphenoid. So in between, we know we have the optic canal through which the optic nerve and the ophthalmic artery would pass through. Lateral to the anterior clinoid process and the body of sphenoid, we have the superior orbital fissure. So this is the place of superior orbital fissure. This is the anterior clinoid process. This is the optic canal. This is the body of sphenoid. This anterior portion of the cella would be called as a tuberculum cella, and the posterior aspect of the cella would be called as the dorsum cella. The same thing, showing it better on a CT image. So this would be the anterior clinoid process. This is the optic canal. This lateral opening would be the superior orbital fissure. And this would be the posterior clinoid process in relation to the dorsum cella. And this is the sphenoid sinus and the walls of the sphenoid sinus here. So as we go further inferiorly in the axial sections, we now start seeing another fissure here, which is the starting point of the inferior orbital fissure. So superiorly we saw optic canal and the superior orbital fissure. As we start going further inferiorly, we would see the inferior orbital fissure, and that's when also the petrous bones start coming in and the superiormost cut of the superior semicircular canals are being visible at this location. So you have the inferior orbital fissure, you have the petrous bones and the superior semicircular canal being placed here. So again, on CT section, we see it better. This lucency within the petrous bone would represent the superior semicircular canal. And this is the initial portions of the inferior orbital fissure, which we are coming across here. Further, we see a better portion of the inferior orbital fissure, a clear portion of the inferior orbital fissure here. As well as in posteriorly, we would see the internal auditory canal through which the 7th and the 8th cranial nerves would pass through. These are portions of the posterior semicircular canal now. So the semicircular canal, the petrous bone having its components being visualized. We have visualization of the internal auditory canal, and we also have these at the same level visualization of the inferior orbital fissure. And this bulge which we see along the medial aspect of the sphenoid sinus would be the portions of the carotid artery, which in the further down sections we would see a proper carotid canal being placed there. So this is that we saw the pterygopalatine fossa in the coronal sections then. Now I'm showing you this in the axial sections. Again, the relationships communicating medially with the nasal cavity through the sphenopalatine foramina, laterally into the intraorbital infratemporal fossa through the pterygomaxillary fissure. Posteriorly, what we see here is the foramen rotundum. So this is a direct connection between the middle cranial fossa into the pterygopalatine fossa. So these are the connections of the pterygopalatine fossa on the axial sections. As I said, that bulge which I showed in the initial section, further down we would see as a proper ovoid focus there, and that would represent the carotid canal. More portions of the petrous bone and portions of the middle ear and the ossicles being visualized, the internal auditory canal here, and now the inferior orbital fissure is almost getting done with. Now, of course, the posterior fossa formed by the occipital bone, and these are again ethmoid bones and the frontal and the sphenoid bones in green being represented. So I'm just trying to show the major structures which we come across in each sections, axial sections as we pass through. So again, this is the inferior orbital fissure, and this would pterygopalatine fissure area, which would communicate with the foramen rotundum into the middle cranial fossa here. So this is again pterygopalatine fossa here, which is seen. This is the carotid canal, internal auditory canal, the petrous bone lodging the middle ear and the inner ear components. Further inferiorly and medially, on coronal section, if you remember, we saw that the pterygoid canal was placed inferiorly and medially and was smaller as compared to the foramen rotundum. The same thing. So we see in further below sections, this another medially placed canal, which is called as the pterygoid canal or the Vidian canal, which connects the pterygopalatine fossa into the foramen lacerum. So the anterior portion of the petrous component of the internal carotid artery would have the foramen lacerum. So that connection is called as the pterygoid canal or the Vidian canal. So here also we can see the other two foraminae, the ovale and the spinosum, quite nicely here. The ovale and the spinosum being placed here. So this is mainly to show these foramens. Of course, the now what we start seeing here is the jugular bulb posteriorly. This much behind the carotid artery. So nice depiction of the ovale and the spinosum here. So on the axial sections, so rotundum we saw was a more horizontally placed, I would say, a foramen on an axial cut, which is better seen on a coronal view. Whereas when you see the ovale and ovale is better seen on both the views, axial as well as the coronal views. And then this is the spinosum, which is a smaller structures, might be difficult to see on a coronal section. Only on thin cuts CT we would be able to pick this up. So ovale and spinosum. And any other important structures here is, so this is a portion of the carotid canal which we are seeing here. Both these portions of the carotid canal. Yeah, so again, the carotid canal, this would be the foramen, this would be the foramen lacerum. Again, you can see a small Vidian canal, better depicted on the left side here. This is the Vidian canal connecting with the foramen lacerum, the carotid canal. These are the basal turn of the cochlea as we come across here. So again, to show these main structures down. On the axial sections, the pterygoid bones, as we see the medial pterygoid plate, the lateral pterygoid plate, in between we have the pterygoid fossa, and behind the maxillary sinus and in front of the pterygoid bones, we have the pterygopalatine fossa. Again, the relations I have already discussed. So this is the pterygopalatine fossa on the axial sections, anteriorly by the maxillary sinus and posteriorly by the pterygoid bones, the vomer, which is seen here. And further posteriorly, this is an important structure here, that this is the carotid artery and this is the jugular vein. So the bone which separates the carotid artery and the jugular vein is called as the carotico-jugular spine. This is an important landmark when we talk about the glomus tumors, which can cause erosions of this spine. So remember this structure, bony structure between the carotid artery and the jugular vein, which is called as the carotico-jugular spine. So this is the nasolacrimal duct anteriorly here. Further, as we go further down, we would now come. So I would like to also cover here the jugular foramen. We have gone through the anatomical this thing before, so we know what components would pass through. So anteriorly would be the nervosa, posteriorly would be the vasculosa. These and the following cranial nerves would pass through that 9th anteriorly, 10th and 11th posteriorly. Further down, we have the hypoglossal canal through which the hypoglossal nerve would pass through, as we see nicely on this section. So this is a portion where the clivus, base occiput portion of the clivus would be placed. And now you can see that we are almost in the nasopharyngeal region as we have come down along the axial cuts. Again, just to show the carotico-jugular spine nicely seen here, carotid artery, the jugular foramen, the jugular bulb, and the bony projection between the two called as the carotico-jugular spine, important in glomus tumors. Further down, when you come in relation to the pterygoid bones, now we see the nasopharynx being covered. We have finished the sphenoid sinus. Now we have come into the nasopharyngeal region. And now we also start seeing the occipital condyles as well as the occipital squama down here. And these ones are the styloid process, which are attached from the tip of the mastoid down below into the extracranial space. So these two dots here would be representing the styloid process. Again, to show this is the styloid process, and these are the nasopharyngeal regions. This is the pterygoid bone, medial and the lateral pterygoid plates. So talking about the hard palate, portions of it being formed by the palatine bone, the maxillary bone forming anteriorly, posteriorly by the palatine bone, and its lateral articulation with the pterygoid bone. At this level, now we start seeing the tip of the styloid process as well as the C1 and the C2 vertebrae. So further down, we see again the hard palate, the pterygoid bones, and the palatine bones being formed. Just to show again the tip of the styloid process and the C1 and the C2. This tip would be the odontoid tip of, that means to say the C2 vertebra tip, and this arch would be the C1 anterior arch. Just to remember that we have crossed across the foramen magnum and come below now to the level of the cervical vertebra. So we have finished CT, coronal, and the axial cuts, and few relevant MRI anatomy, which is important to note. In the anterior cranial fossa, it is the presence of this olfactory bulb. Again, we have talked about the anatomy, which I will not be repeating again here, just to show the olfactory bulbs, which appear like this, and these are the gyrus recti, which are, and posteriorly, we would have the olfactory nerves coursing behind as we go from anterior to posterior direction. So on the sagittal view, we can see it better, the initial olfactory bulb, as we see here on the sagittal MRI image, and a thin olfactory nerve which passes through posteriorly. Similarly, on the axial cuts, the olfactory nerves which go posteriorly from anterior aspect of the olfactory bulbs. This is the optic chiasma, the X-shaped structure here. Another important structure is the foramen ovale, which we saw across on the CT cuts, a similar thing on the MR. So this is a nerve, the mandibular division of the trigeminal nerve, which passes through the foramen ovale. So this is the foramen ovale on the, again, the corresponding CT cuts. This is the MR cut, T1 weighted image, where we look for the anatomy on T1 weighted image. And this is the CT cuts for the same to show the location of the foramen ovale. On MR, we have image called as the Fiesta or the CIS images, where we can try to depict these smaller cranial nerves within the cavernous sinus. So that's why I showed that anatomical figure to remember. The medially would be the carotid artery, immediately lateral to that would be the abducent nerve, and then further laterally would be the trochlear nerve. This would be the oculomotor nerve, and though we can't see the two divisions of the trigeminal nerve, a faint visibility of a trigeminal portion of the nerve is seen. So it is possible sometimes for us to demonstrate this when we use a special sequences to depict the cranial nerves called as the Fiesta or the CIS sequences. Always remember on MRI, anything bright on a T1 weighted image is good for us. So T1 bright is good sign, that is just fat for us. So look at the petrous bones, this is the area of the petrous bones. The fat being placed there just means to say that everything is fine, that is normal bone marrow being placed there. Okay, so having looked at some of the important points on the MRI, so when do we do CT, when do we do MR? The CT, of course, for bony anatomy, also to look for fibro-osseous skull lesions, and of course, when you want to look at the neural foramina per se. Whereas MRI is very important when you have to look for the brain, when you have to look for the dura, when you have to look for the meninges, and when you have to look for the neurovascular involvement. MRI would be a better imaging modality. So just to finish with few pathologies, so we can broadly divide them into congenital and developmental, infection and inflammation, and of course tumors. So just coming to the congenital abnormalities, which will include the encephalocele. Again, here you can see the defect in the cribriform plate area here. And this is the herniation of the CSF component, and this is the herniation of the gyrus rectus. So this is nothing but encephalocele coming across the defect in the cribriform plate. So, and nasoethmoidal encephalocele. Same thing on a coronal T2 weighted images, just showing the same, that the herniation. See the difference here. There is a CSF cleft between the brain and the nasal cavity, whereas that is lost on the left side with the herniation of the brain parenchyma into the ethmoid sinus there. Similarly, on the T1 contrast images, the same thing is being depicted. Of course, rarer encephaloceles, which would include the basal encephalocele, where you much posteriorly than the cribriform plate, which was anteriorly. Here, the planum sphenoidal is not formed at all. So this is predominantly a problem with the sphenoid bone, through which there is herniation of the CSF and the brain contents through which through the defect, and this is the pituitary tissue which is seen herniating below it. So this is the basal encephalocele or the transcellular or the transsphenoidal encephalocele. Some tumors like the fibrous dysplasia, where you can see the expansion of the bones with maintained cortical margins. We look for ground glass matrix within. So this is a characteristic ground glassing appearance of the matrix. So if this appearance is there, we know it's a classical fibrous dysplasia. The importance of this is it can cause cranial nerve or the neural foramina constrictions. So that is an important thing to know about the fibrous dysplasia. Similarly, on the axial sections, MR for these tumors is going to be confusing for us. It will look like some malignant tumor or some infection going on. So always for these kind of tumors, it's better to have a CT correlation rather than just having MR images. Always remember I said bright signals on T1 weighted images on MRI is good for us. Here we see there is a loss of the bright signal, suggesting that it's a pathology. And I'll always do a CT to detect this fibrous dysplasia. So it appears quite heterogeneous hypointons on T2 weighted images, can show enhancement, can easily mimic a tumor or an infection. Another important thing to remember is the arrested pneumatization of the sphenoid sinus. You can see the normal sphenoid sinus pneumatization here, whereas here it's a well-defined kind of an expansile, but having well-defined margins, bony margins, and kind of sclerotic foci within. Again, on the coronal view, sinus pneumatized, unpneumatized sinus here. So these are all normal variations, should not be confused for tumors. Similarly, on the MR images, we can see the T1, T2, this is a T2 weighted image, where we see the bright signals of this, which is maintained fat. Again, on the T1 weighted image, we see the bright signals, which is maintained fat, saying that it is normal and we should not be confusing for a pathology. Similarly, if you actually see that arrested pneumatization has similar signals to that of the petrous apex here. So we know that this is also a normal component. It is getting suppressed on fat. That means to say it is a fat containing marrow, bone marrow there. So it's a normal arrested pneumatization of the sphenoid sinus. Infections, inflammation, I think we have seen lots during this pandemic. So I talk very less about that. Just see mainly to show the skull base hyperintensities, the petrous bones hyperintensities, the intratemporal fossa hyperintense signals suggesting. And also usually these are associated with otomastoiditis as we see fluid signals within the mastoid cavity and the middle ear. So on this, we see that, there is a lytic objective involving the carotid canal. I can see here the carotid canal, the normal foramen ovale, they are all lost on this side. There is erosion of the lateral wall of the clivus on this side as well. So, and this, the same area also shows a lot of enhancement on the post-contrast studies. So these are typical pictures of skull base involvement, osteomyelitis. So this is a MR angiogram where you can see this internal carotid artery, this venogram overlap as well. But what is happening to the artery here? You can see irregularity, multiple lobulated appearance of an artery here. That is nothing but a pseudoaneurysm because of a, again, skull base osteomyelitis. Here you can see a lot of heterogeneous signals within the internal carotid artery here. And because of that, there is an embolic stroke in the brain with hemorrhagic transformation. These are some sequences which we call as gradient to pick up the blood, just to show that there is hemorrhagic infarcts caused by that pseudoaneurysm. Again, we can see the normal carotid canal on the right side here, the abnormal carotid canal being destroyed by the infective process. You can see the normal pneumatized mastoid in the middle ear here. You can see the soft tissue opacification within the middle ear and the mastoid air cells. So these are all the features of an infection. Of course, when you see hyperdense contents, we start thinking about fungal because of the their components of iron and manganese and so on. So when you have a fairly expansile paranasal stuffing or mucosal disease with maintained margins, with no invasions and hyperdense contents within, we are talking about non-invasive allergic fungal sinusitis in such scenarios. Same thing visualized on the T1 weighted images and the contrast. So this, you should not confuse this with the invasive varieties of fungal. That would be a totally different thing. As we saw in the skull base osteomyelitis, the picture would be something like that, unlike here. In hyperdense contents, are usually a feature of non-invasive fungal sinusitis and not a feature of invasive fungal sinusitis. And why that happens is because of their paramagnetic iron and manganese within these fungi. A few other lesions should not be mistaken for a tumor. And this would be the petrous apex lesion here, significant thinning of the bone, as we can see some cortical breaches as well, and isodense area here. The most important flinching point in such scenarios would be the intensity of the lesion on a T1 weighted image. So already lesions which are bright on T1 are usually going to be benign. As I've said, T1 bright is helpful for us. So this is a cholesterol granuloma, not some malignant condition, right? So same thing on a coronal T1 weighted images. Another important thing is the anterior clinoid process. Here, see a well-defined anterior clinoid process on the left. This is appearing slightly swollen with loss of its cortical margins. So this is a mucocele at the anterior clinoid process, which is causing compression of the optic nerve. Normal optic canal here, that's being compromised on the right side. The same thing on the T1 weighted image. Again, T1 it is bright, suggesting it is a benign process for us. Again, T1 it is bright, suggesting a benign process for us. This is the left optic nerve, normal. This is the right optic nerve, which is compressed. So anterior clinoid mucocele compressing the optic nerve. Last, coming to tumors. Some of the tumors which we see everywhere are the chordomas, lymphomas, meningiomas, metastases, and multiple myelomas. So these are typical examples of olfactory meningioma along the olfactory groove, hyperdense lesion on scan, well enhancing on the contrast, a lot of flow voids on the T2 weighted images, and some edema in the brain. So a typical lesion of this sort in the olfactory groove would be the olfactory meningiomas. And we also have another lesion here, which is placed in the superior nasal cavity as well as in the anterior skull base, with the waist being at the in between. So this is a typical example of a olfactory neuroblastoma. Another important thing is they usually have peripheral tumoral cysts being placed along the superior border of the lesion. So the placement of these lesions gives a clue to what type of lesions this could be. Again, to show the contrast enhancement, very avidly enhancing lesion. In the middle cranial fossa, avidly enhancing isodense lesion on plane, and with contrast, it is nicely enhancing lesion, which is seen here in relation to the sphenoid wing. So this is a sphenoid wing meningioma. Same thing on the T2, on the MRF images, the T1 being hypointense and the T2 being heterointense there. In relation to the wing of sphenoid, so sphenoid wing meningioma. This is more laterally placed in relation to the cavernous sinus. So you can call this as cavernous sinus meningioma. Normally it encases the internal carotid artery here, which is narrowed. As we can see, this is also encasing the portions of the terminal ICA and the proximal middle cerebral artery. So usually meningiomas will encase these vessels and cause their narrowings, as compared to say some other tumors like schwannomas and all, which will usually not cause narrowing of the arteries. So again, another image here showing the narrowing of the arteries and being encased by the enhancing lesion. That is the cavernous sinus meningiomas. Coming last to the posterior cranial fossa tumors, the petro-occipital or the petroclival synchondros is an important place where chondrosarcoma would arise. So on a CT, they have typical this cartilaginous matrix having arc and ring-like calcifications. On the contrast, they also have some soft tissue component which enhances. So that area would be quite typical for a chordoma. And here we can see that on the T2 weighted images, there is quite heterointense lesions. So these are ossific components which are placed. So suggesting that this is a cartilaginous based tumor having ring and arc like of calcification, suggesting chondrosarcoma in the petro-occipital area. These are usually para-midline, whereas when you come to the midline, the another common differential which we have is the chordoma. Again, the contrast enhancement just to show that lesion. So talking about chordoma, as I said, the midline lesions in the clivus would be the chordoma. Also another area where they can involve is in the C2 region, where you have a classical T2 hyperintense lesion saying that it is a cartilaginous based lesion at the odontoid tip. And this is called as a thumb sign. It starts protruding and compressing the cervicomedullary junction as we see here. So this would be a classical case of clival, not clival, sorry, the C2 chordoma here. Jugular foramen area, again, we know there's a nerve-related, nerve-rich area. So we can have a schwannoma, which is a homogeneous lesion. Also, as you can see, a homogeneously enhancing lesion. Also, what we see is a vascular rich area. So we can also have a jugular, the paragangliomas being placed there. So this is a salt and pepper appearance, heterogeneous T1 and T2 phlovoids being placed within the lesion. Once this appearance is there, we know that it is a highly vascular lesion that makes it the glomus jugulaire as against a schwannoma. So these are the two. That's why knowing what contents pass through each area becomes important, because it makes our differentials much easier. So again, well enhancing on the post-contrast image, showing that jugular tumor, and on the CT we can see the erosions. So this is a normal carotid spine, which we talked about, carotico-jugular spine, that is being eroded and being replaced by this mass here. So classical components of a glomus jugulaire. Yeah, so I think in this I try to initially cover important anatomical aspects, try to show them, represent them on the coronal and the axial sections of the CT. Told what is important on MR, what is crucial information such as the T1 being bright is something good to note, followed by some few examples just to help us understand these areas of foraminas much better. So thank you.
Thank you, Dr. Ullas. Hello.
Yeah, I can.
Hello, Rashmita. Hello. There are few questions. Hello.
Yeah, tell me.
Sir, there are few questions, sir. First question is, how often we see pneumatization of crista galli?
Pneumatization of crista galli, I do not know the percentages like that, but not very common to have. I would put it that way. I do not know the exact percentage to comment on that, but we do not see it quite often as such.
Okay, sir. Thank you. Second question, for CSF rhinorrhea, which is the ideal radiological investigation?
Yeah, so CSF rhinorrhea, see, if it is active, and we could start doing an MR cis images, which would pick up if there is a definite leak. It would show us the area of the leak. We would see that as a CSF intensity leak coming across the cribriform plate. If the question is more about the sensitivity, of course, the CT cystonogram would be more sensitive enough most of the times. So if I would say this way, if the patient is, say most of these people are post-traumatic and they might not be in a position to be placed in supine or in prone positions. When we do a CT cystonogram, we invariably need to do in prone. We inject the contrast in the subarachnoid space and then make the patient prone. So there's a lot of maneuverability which we need to do with the patient. So if the patient is able to do that, then that would be the best investigation to do. But in post-traumatic people with a lot of fractures and things like that, that might not be possible all the time. And those situations, we can always do a MR cystonogram, which can be done without contrast. So if you ask between the two, the sensitivity and specificity of picking a leak would be much better with the CT cystonogram, provided if you are not able to do CT cystonogram for some reason, or if there are issues of radiations and things like that, then we could also do a MR. MR also, if there is an obvious leak, it helps us to pick up better. MR, where it scores over CT cystonogram is if there is an associated, say, encephalocele, or we see through the Sternberg's canal, the brain parenchyma protruding into the sphenoid sinus. So for those reasons, MR would be better, but we would not know this initially, right? So in that way, to identify the leak in post-traumatic cases, it would be still CT cystonogram if the patient is being able to, if that maneuver can be done to the patient. Otherwise, we could do an MR as well.
Okay. Thank you, sir. So one more question. What is the normal size of foramen rotundum? When do we say it is enlarged or eroded?
Okay, so again, see, it is quite easy if you just see the opposite side. So no need to go by measurement. So one thing, it should never be as large as the foramen ovale, because ovale is the largest foramen. So compare it with the foramen ovale. If it is smaller than the foramen, if it is equal to or larger than the foramen of ovale, of course, it means that it is a dilated foramen. The simple thing would be to compare it to the opposite side. So you have a symmetry. Always in head and neck, symmetry is very, very important. So whenever there's an asymmetry, you start thinking about a pathology. So look at the symmetricity and look at its relation with foramen ovale. That would be my answer for that.
Thank you, Dr. Ullas.
Yeah.
Complicated skull-base anatomy was made very easy. Thank you very much.
I hope I am not confused.
No, thank you.
Yeah.
Thank you all.
Yeah, thank you. Thanks.